And welcome everyone.
Right.
Thank you for joining us for the hospital-initiated opioid overdose programming, engaging patients in care coordination, also known as EPICC. I would like to start with a couple of reminders. This session is being recorded and will be available on the conference platform after this session ends. Please keep yourself muted unless the presenter or myself asks otherwise. Make sure to join the sessions live today because we will be doing a prize drawing from attendance within each session. The conference is also offering free continuing education credits. For more information, please visit the continuing education page. And without further ado, I'd like to introduce Sean Billings. So a little bit about Sean. Sean currently serves as the Vice President of Substance Use Programming for the Missouri Hospital Association. Previously, Mr. Billings was employed as a treatment court administrator for the Missouri State Courts. He has over 15 years of experience managing local, state, and federally funded programs to enhance and expand behavioral health treatment services for the high-risk and high-need populations in both rural and urban settings. Throughout his career, he has also served as a federal grant peer reviewer, an adjunct faculty at Drury University, and as the alderman in the city of Battlefield, Missouri. So, ladies and gentlemen, please join me in welcoming Sean Billings.
Thanks, Johnny. Good afternoon, everyone. So I want to focus on 4 words in this title real quick, and it's "It Takes a Village." And Adrienne, who kicked us off this morning, she said something that resonated with me, and that was multifaceted problems demand or require a multidisciplinary approach. And it just really hit home for me. And I want to preface this entire slide deck just by saying none of this work, any success that we've realized, it was certainly not done in a silo. It was done by standing on the shoulders of everybody else and working alongside a lot of other people to drive this work. So let's see if I can figure out, there we go. So I have nothing to disclose. It's just little old me talking about this stuff. So we've seen a couple different iterations of this, and what we're looking at is basically the 3 waves of the opioid epidemic. And I like this visual. I'm a very visual person, and I'm not going to spend a lot of time. We've had 2 other presentations that really drove this point home, but to me, this really speaks to one word when I look at this, and it's economics. And when I see this, and it really speaks to the prevalence, and you can see how we've really, changed the focus from opioids, heroin, and now synthetics. The 4th wave, methamphetamine. Even though this has been lifted up and spoke to over the last, year, this is something that, just because I've been in the trenches, and most of us have for, years, decades, this has been prevalent. Maybe not in all of our communities, but certainly within the Southwest region and other pockets for some time. It's just based on, folks, our community members losing their lives. It's really calling attention to this issue in our communities. And I'll tell you that it is very hard these days to find methamphetamine in our communities that isn't cut or laced with fentanyl. It is a big problem. And we know this just through interdiction efforts, working with our high intensity drug trafficking area officials. We know this from working with the Drug Enforcement Agency, local law enforcement, sheriff's department, state patrol, so on and so forth, as well as the community members that we serve through our ADA providers and our hospitals, healthcare system via tox screens. We know it's in their systems. We know it's on the streets. Now, this right here is just a little dated. We all know, but the fact remains, whatever ground we made in 2019 based on integrating all of these evidence-based practices and really aligning all the great work that's going on in each of these states, whatever ground we made, we lost in 2020, 2021, and then some. So that stat, if I updated it through the provisional data, as we've learned through 2 other sessions, is 93,331. Way too many. So I don't expect us to ingest all of these numbers right here. And hopefully it's not diluted too much on your screens. But when Dr. Farr spoke to the importance of gaining a better understanding of geographic variability, here's one small example from one data set via the Missouri Department of Health and Human Services of us taking a closer look at some of that variability. And on this next slide, I'm going to call out some of the highlights that I'd like to call to your attention. But before I do so, one of those bullet points that is not, that I do not address, and that is in the central region. And I want you to look at this 188% increase that's in the central region under Black from 2019 to 2020. That is one of the most alarming statistics on here. In aggregate, in aggregate, we're looking close to a 20% increase, and we can see this through national data as well, from 2019 to 2020. This data right here is specific to Missouri, but it does do a really good job to really give us a cross section of what our different communities are seeing, right? And there's a lot of things that go into this data, as we all know. What type of surveillance infrastructure do we have in each of these communities? How well are we reporting out? Fidelity with the data capture. So there's a little bit of nuance with this data, and I totally get it. But I think in broad strokes, this at least begins to tell the story of what's going on in our communities. And it allows us to make informed decisions with the limited resources that we have to focus within each of our states. So some of those bullet points that I'd like to focus your attention to, I'm not going to read all 8, but 1B. So under 1, overall drug overdose deaths increased approximately, again, 19% in 2020 compared to 2019. 1B, deaths among Black people increased 32% compared to 15% among white people. So to me, this really speaks to disproportionate representation as far as who's accessing services and who isn't accessing services. And it really gives us a really good foundation to start asking those questions of why. Why is this? And getting together, again, it takes a village, a multidisciplinary approach to really start speaking to these communities, boots to the ground at a grassroots level, to start asking some of those tough questions of why. Why are we seeing this in our communities? And then when we look at this disproportionate representation, do we see discrepancy between Eastern region and Western region down in the Southwest? And the answer is yes, we do. Bullet point 3, the Northeastern region had the only percent decrease, or had, I'm sorry, I don't want to call your attention to that one. Slide number 2, the Northwestern region had the largest percent increase in total drug overdose deaths, 52%. Now, granted, when you look at the end and the total number of community members, it's not like the density that you'll find in St. Louis City, but is this still alarming? And particularly for those community members that are losing loved ones? Absolutely. And it really speaks to, again, focusing limited resources as appropriate to those communities that need our support and that need more access to evidence-based treatment, recovery, and prevention efforts to really get a better handle on this. I would also call your attention to to bullet point 6. Overdose deaths involving a combination of opioids and stimulants increased by approximately 57% statewide between 2019 and 2020. So again, what we're seeing nationally, we're certainly seeing on Missouri soil, and this is a problem. Other folks have spoken to some of those federal funds and grants, specifically back in 2017, the state targeted response grant that was given out to all 50 states nationwide, funded from the Substance Abuse and Mental Health Services Administration. Now it's the state opioid response grant. And now we're in state opioid response 2.0. And we recently learned not too long ago that the feds are going to fund a 3.0. But as we look at that funding, and as we know, some of those funds are being dedicated to stimulant use disorder as well, because we see that in all of our communities. So again, making informed decisions based on data to focus limited resources in our communities based on what we're seeing in our streets, in our communities, in data.
Hey, Sean.
Yes.
Hey, real quick, this is just kind of a geographic question here that I'm unable to answer. Is Central Missouri increase in Columbia, the University of Missouri area? That was a question.
Yes. So, and actually the next slide, I believe, I get into a community event in Columbia, and I hope, I'm hoping that I hear the question right. And the question is, just to repeat this back, are we seeing an increase in the central region, specifically Columbia, specific to overdose deaths? And the answer to that is yes. And I want to speak to something that Lisa and Knox spoke to, just real quick. And that's the importance of prioritizing community-based distribution efforts around overdose education and naloxone distribution. So going back a couple of months ago, one of our staff members that served through our hospital-initiated opioid overdose program, EPICC, that I'll get to in a little bit, they were at a community convening and they were just talking about our program. And it just so happened that we had a fire chief from Columbia in the audience. We had a couple police chiefs. At the end of this convening, they went up to some of the EPICC staff and they're like, you know what? I really appreciate, the presentation, but do you have a few minutes? I want to tell you about what we're seeing. And this data right here, what they did is the police department, along with the fire chiefs, they looked at their own databases, and between January 1st and October 1st, they responded to 200 calls from community members that needed more than just law enforcement and the first responder, right? They needed substance use treatment. They needed recovery. They needed someone to help them out. Of those reports, they documented that 131 people were experiencing, in fact, an overdose. And of those, 22 deaths occurred. We lost 22 community members. And what they decided to do was, again, it takes a village. This is a multidisciplinary approach. We have law enforcement, first responders reaching out to the local Boone County Health Department to start talking about, well, what do we do? How can we unify? How can we get together and really highlight and raise this awareness and educate our community? And what they decided to do was they picked a high school. They convened a community event that was spearheaded by the Boone County Health Department in conjunction with a lot of other folks, including our law enforcement, fire chiefs. We had the Department of Mental Health there. We had a lot of local representation as well. It was a wonderful convening, and there were tears shed, powerful testimony was given. We handed out 242 overdose kits. But the overarching sentiment at that convening was a couple of things. One was, why haven't we done this sooner? And I'm speaking on behalf of just, the broader community sitting out in the audience. on one hand, they appreciated so much that you had fire chiefs, police chiefs, and other representation from the community really highlighting this issue. And also they wanted more of these, right? And at the end of that convening, several community members stood up and said, well, when is the next one, right? We want more information and we have more questions, because we had to cut it off. This started at 7 p.m. and myself and some others didn't end up walking out of there until after 10, which really just speaks to how thirsty the community was for more information and how to, what is going on here in our community. We want to know more. Tell us about Narcan. Tell us how to identify signs of someone in overdose. So hopefully that answered that question, but I will speak, just candidly about data that I have in my purview. This is outside of this via hospitals and via our bridge model within the Columbia community. Absolutely, we've seen an increase in overdoses. And we're trying to do our best to get ahead of it. And part of that recipe is engaging our community more thoughtfully and raising awareness on this issue. And then also some action in there, right? Providing the overdose kits to the community members, and hopefully springboard from this convening to ongoing convenings, not only in the Columbia community. I'd love to see this footprint throughout the entire state. So some key challenges facing our state. And I know this isn't certainly unique to the state of Missouri. Nationwide, we need more staff, whether it's more physicians that are willing to get buprenorphine waivered. We need more recovery coaches. We need more psychiatrists. We need more social workers. We need more community members that go into professional tracks in behavioral health, period. We need more. And we see it in surveys that we have workforce shortages. We see it in national data. We see it in statewide data. Medicaid expansion, even though Missouri did recently pass, and I believe Kansas is already a Medicaid expansion state, now a lot of the hard work is still, yet to take root, where we have to figure this out, get 275,000 Missourians enrolled that are now eligible to get plugged in. So this is really going to be a game changer to increase access to evidence-based treatment and to get folks squared away. The prescription drug monitoring program, Missouri was the last state to have a statewide legislated PDMP. We successfully did this last round. But again, now the work's starting. It's via Senate Bill 63. And really the first charge is to assemble an opioid task force to discern who that statewide vendor is going to be to drive this platform. And I'm going to get into this in a little bit down below, but just a real quick plug for St. Louis County Health Department. Back in 2017, they launched an internal PDMP with reciprocal agreements ingrained. So basically right out of the gate, if any other city, county in the state of Missouri wanted to latch onto their system, they were more than welcome to. And again, I'm going to get into this, but just real fast. Well, what does that footprint look like today? Today, we have 85% of Missourians covered, and that equates to about 93 to 95% of all healthcare providers. So still a little wiggle room to improve. I'm hopeful that we leverage that existing PDMP so we don't have to reinvent the wheel, or St. Louis County is heavily involved in what our new system looks like. Diminished access to medication-assisted treatment. I think this is certainly not unique to Missouri. We need more prescribing power across the board. This is something that Lisa and Knox spoke to earlier in their presentation. Social determinants of health. I can't think of any facet of what we do and through our service to others where food insecurity, childcare needs, transportation barriers, homelessness don't impact our ability to serve thoughtfully in this space. Oftentimes, before we can provide these evidence-based treatments, and recovery assets to the people we serve, we have to deal with where Sean is going to lay his head each night, where Sean is going to get his next meal, so on and so forth. That's super important that we think and design programming that at least does their best to address those concurrent to the underlying issues. Because it's been my experience, if we do not take care of the other issues, the important quality of life, social determinants of health, home, transportation, food, we're not going to get anywhere through our service. Stigma, I could talk about stigma for hours and hours, and I think we're all aware that it's real, that each of us have stigma within us. It's a matter of perceiving use disorder as a chronic brain disease and not as a moral failing. And I know sometimes that's easier said than done, but it's true. And we have to really look at this as a chronic disease, and we need to start treating our community members as such. And that means getting and opening up access to medicines and really being intentional and thoughtful with how we treat folks. We heard Damon earlier, and what a great presentation. But the things that he spoke to that really resonated with me was things like, even though I didn't say this, really meeting people where they're at, being very mindful and intentional with the thoughts that we have, the words that come out of our mouth, knowing that that is super powerful and can really change our environment around us, carrying that positivity with us. I think all of that plays weight into how we treat folks, how, just how well we do our jobs through our service and others, because body language, all of that plays weight into the reception of the gifts that we give to community members that we have the privilege of serving. COVID-19, it has impacted every facet in my small world through my work at the Missouri Hospital Association through this work. And I'm sure the same is true for all of you. And then fentanyl, I think we've heard a lot about that. The increased supply of fentanyl and stimulants in our communities is just aggravating an existing issue that we've had in our, so sorry for that. One of my neighbors has a Harley, and he decided to leave right there. But yes, we know fentanyl is an issue. So core strategies addressing substance use disorder. So again, this is shared amongst many states, but legislative advocacy. Now, more recently, we focused on the PDMP and Medicaid expansion, but so too with our Good Sam's law, we have some work to do, right? We certainly don't want fentanyl test strips to be qualified as drug paraphernalia. Why? Well, because we too perceive it as a harm reduction strategy, and we want to get that in the hands of as many community members as we can. And the reason is because we know fentanyl is in every nook and cranny within our state. Legislative advocacy, I spoke to that, integrating the medication first model. And I know I don't get into that until a couple more slides, but I just want to speak to that real quick. That is nothing more than realizing, appreciating, and integrating the efficacy of pharmacotherapy within our day-to-day business within our state. Proof is in the pudding. We know that Vivitrol, oral form naltrexone, methadone, as well as buprenorphine, they're efficacious, they work. So we did everything in our power to shave the red tape, the bureaucracy, to try to get Sean's and other community members into medication-assisted treatment appointments as soon as we could for those community members that struggle with opioid use disorder. Because we wanted to get them away from intense cravings. We wanted to get them out of withdrawal, because if we didn't, we knew this would happen. Once Sean got released from the emergency department or some other community-based organization intervening acutely on my behalf, if I am not offered a medicine, if medically appropriate, I'm going to go back on the street and use. You can take that to the bank every day of the week, because I don't want to feel poor. And it's not like I'm rushing out to the street so I can get high. It's so I can function and I don't feel awful. So that's the medication first model. Augmenting ADA workforce to include certified peer specialists. This is something that Dr. Farr, Dr. Hagel, Dr. Liu spoke to, is just the importance of really digging in and seeing how this is working, right? And then providing people like me with that information. So then we can tinker with our program and then make both micro and macro informed decisions based on data of how we can serve more thoughtfully, right? Maybe if we do this, we can extend retention in our program so many months. But without that information, everything's anecdotal. So we definitely appreciate our researchers, and there is certainly tremendous opportunity for us just to do more in that space. Relationship building and stigma reduction initiatives, connecting the dots, which I'll speak to a little bit later, is one example that they do a really good job of just getting out there, beating the war drum, and trying to diminish some of that stigma statewide. So just real quick with PDMP in the state of Missouri, I kind of spoke to a lot of this already. One thing that I want to highlight though is our goals, right? What are we trying to get out of this? And this certainly isn't unique to the state of Missouri. This is true for any PDMP that is operating fluently and as intended, right? Number one, we want to improve controlled substance prescribing by providing critical information regarding my history, right? If I have multiple physicians, whether I'm doctor shopping or not, I want my primary care physician to know what any specialty physicians are prescribing to me. So they can prevent any sort of lethal cocktails, if you will, that might throw me quicker into respiratory depression. For example, if I've got a psychiatrist that has prescribed me a benzodiazepine as an anxiolytic for my anxiety, I want my other doc, Doc B, to know that, if he's going to prescribe me, some opioids because I hurt my back, I'm a construction worker, I want him to ping that PDMP. I want him to know, because maybe I forgot, or maybe I'm just not forthcoming for whatever reason with that information. So unbeknownst to that physician, by prescribing me that opioid, he's placing me at a higher risk of respiratory depression because I have this other medication on the side. So again, super important. Inform clinical practice by identifying patients at risk. Number two, and then also three, reduce the number of people who misuse medications or overdose while making sure patients have access to safe, effective treatment. And I think we're doing a much better job of seeing, those physicians and those practices that are prescribing well above the threshold, the national standards, which is 90 morphine milligram equivalents. It's not to say that those practices or physicians that prescribe over that isn't justified. Definitely not saying that. I think when you look at the geriatric population, when you look at chronic pain management, oftentimes you're going to find those types of situations. But again, you have to seek that appropriately within the practice and the malady. But that being said, there's also, just some egregious prescribing practices that have gone on historically that the PDMP can just help tighten up and offer a layer of, I don't even want to say accountability, but more information, so we can make better decisions regarding client care, and we can protect our patients better, our community members. So important. So again, here I've already spit out these statistics, but again, I'll just give a plug for St. Louis County. Wow, what a great job they've done over the last 4 years, knowing that we didn't have a statewide infrastructure. And I mean, they're just wonderful partners in the state, and they've really done a great job to create this. And this is just a heat map, a state map with those participating. So medication-assisted treatment. And I want to pause just real quick. Any questions, Johnny, that I need to, sorry, I'm using like a little screen here, so I don't have all my things up.
No, you're good, Sean. A couple of people are praising you for the Missouri efforts in the PDMP. So outside of that, you're good to go, man.
All right, perfect. Sorry for the brief digression, y'all.
Hey,
Okay,
if you
so-
need a moment to take a drink, that's cool.
Oh yeah, I got my drink in. All right, so medication-assisted treatment. Let's talk about pharmacotherapy for a little bit. And I'm not going to belabor a lot of these points. We've had a lot of wonderful presenters that have already touched on this, but it works, right? And one thing that I'll say real quick, and I believe Lisa brought this up, and I can't agree with her more, and she was just speaking to the tremendous opportunity we have within our judicial system to do more in the space of integrating pharmacotherapy, medication-assisted treatment in those dockets. Now, I'll tell you, in the state of Missouri, I can't speak so much for the state of Kansas, but in the state of Missouri, we do have a lot of treatment courts. We have several national mentor courts in our state. And, one thing I'll say is those mentor courts, they definitely integrate pharmacotherapy, medication-assisted treatment through their practice. And having served as a treatment court administrator for the 31st Circuit, which is Greene County and Springfield in Missouri, and then also for the 39th Circuit, which is Berry, Stone, and Lawrence counties. And if you're familiar with Branson, Missouri, that's sort of that bucket down there. And then Stone and Lawrence comes up there. But one thing in those, serving those community members that were justice involved, I had the privilege of seeing firsthand of the Sean Billings that walks in front of Judge Blankenship and shakes his hand on the first day, just a rap sheet this long, right? I mean, just huge rap sheet, a lot of poor decisions, but a good person, right? That individual that shook Judge Blankenship's hand on day one, granted our programs were 18 months in length, and on that 18-month day, those treatment court participants who participated by choice, we didn't force it on them, in medication-assisted treatment, they were knocking it out of the park. They were much more successful. We held on to them much more longer than those treatment court participants that chose not to participate. Again, proof is in the pudding, and I cannot speak enough just to the efficacy and really seeing this transform people's lives firsthand, of reclaiming their future, reclaiming their families, getting grounded in recovery, getting jobs, being taxpayers. So I would underscore Lisa's sentiment, and anything that anyone in this conference can do just to help lift up our justice system and help inform, educate, endorse, align your efforts with theirs, I would strongly encourage it. There's a ton of great judges out there, wonderful prosecuting attorney's office. People just have this sentiment like, oh, they're just going to throw the book at you. They're just going to lock you up. That's not my experience. My experience is they ask a lot of tough questions, and it's our job to do that education for them, right? And to use our science and use our research and our findings to help pivot that ambivalence and to start creating change. And that's certainly not unique within the judiciary. I think you could put that template on any organization, any workforce sector. We know who endorses MAT. We also had a slide here. The only thing that I would add to what has already been shared today is one of the gold standards via our program, which I'll speak to in a little bit, EPICC, is when our community members present to the emergency departments, the gold standard for us for that acute care at the time that Sean Billings presents to that ED is buprenorphine. And, there's a lot of sentiment out there, once I land in that emergency department as far as, well, we need the buprenorphine waiver to do the induction. We need, to get the Data 2000 buprenorphine waiver to do a bridge prescription, or to follow me through maintenance care. And there's a lot of merit to all of that. But at the end of the day, taking those extra steps means that Sean Billings isn't coming into your ED 30 times a month. It's just that one time. And that one time I come in, that induction occurs, that bridge prescription is provided, and that connection to the community, which is also important, can take root if there's programs in place to make that happen. And EPICC is just one small program that's sort of our whole purpose. And that is making that linkage and connection at the community level. Now, I'm not saying that buprenorphine is definitely the end all be all. There is a place for methadone and naltrexone, and there's certainly a place within our EPICC model for all three. And we use all three. Some are more cost prohibitive than others, and some are more medically appropriate than others. I'm not a physician. I leave those medical determinations to our MDs, our nurse practitioners, and other practitioners who are eligible and have that clinical discretion. I just know that it works. So the medication first model, again, we're trying to address those withdrawal symptoms. I mean, they are intense from what I hear from community members that I've served for over 20 years now, reducing those intense cravings that they will, between the withdrawal, the cravings, and the way my body feels. Again, if I don't have a medication to help curb and ameliorate that, I want to go out and get something just to make me feel whole so I can function. It's not about the euphoria anymore. It's just about me being able to just get up, operate, function, enable the patient to focus and engage in counseling. I can tell you, I hear it very often. Oh man, Sean or Mr. Billings, I can't tell you, I'm getting more, entrenched in my recovery. I'm going to meetings, stuff's starting to sink in. And often what I hear is the reason why they can receive these gifts, this treatment, is because their head is calm to a place. And I attribute to some medication, and that's what they qualify that peace or that quiet to, is the medication they're on. And that's both methadone, that could be Vivitrol, that could be buprenorphine. Again, it's creating that safe space for them to really engage in the counseling and the social supports that they need to really retain that recovery. Increased treatment retention, and it's supported by the Missouri Department of Mental Health, and it is a key component of our state opioid response grant. And it has been back in 2017 when we were the state targeted response grant. So barriers to MAT. Lisa and Nuck also spoke to just, gosh, we need more bup waivered physicians, practitioners that can serve in the space. But they also spoke to, gosh, why is it the only drug out of all the scheduled drugs by the DEA where physicians can prescribe everything except buprenorphine? So now you're telling me I've gone through med school and I've done all this, and now I've got to go through 8 hours of this training just to prescribe this one medication. Well, yeah. Now, if I'm a nurse practitioner, you can times that by 3 because I have to do 24 hours. She also spoke to some grace that's been extended recently, and that being, if I'm okay with not maintaining 30 community members, 30 patients, then I don't need to jump through all of those hoops, which is true. There's nuance therein. You have to have your licensure, you have to have your DEA number, but that's absolutely correct. Something else that I'll say is, if you are a practitioner working in the ED and you can prescribe, there's something called a 3-day rule within buprenorphine, where you don't, and this is pre Biden administration, just the waiver that to open up. You don't need to have the Data 2000 Bup waiver as long as you don't maintain 30 patients. And the 3-day rule is nothing more than this. You can prescribe 1 dose of buprenorphine per day for up to 3 days consecutively without having the Data 2000 Bup waiver. Now at 2 a.m. at Saturday morning, when I get an EPICC referral, that means everything to that community member, right? Because at 2 a.m., where in the world are they going to get a buprenorphine appointment, medication-assisted treatment appointment with one of our docs that we leverage at the community level? Well, I'll tell you, they won't. So if they don't get that first dose of buprenorphine within that ED, and then also I would take it an extra step and advocate for that bridge prescription. Because if I come in at 2 a.m. on Saturday morning and I get that induction, that's going to wane after about 18 to 24 hours. Now I need my second dose. Well, it's Sunday. Now I still have to wait till Monday, best case scenario, to see that doc. So that bridge prescription of 3 to 5 days gives additional grace to me, the community member, working alongside whoever that clinical team is to get me squared away at the community level once that script runs out. Community services for supportive treatment, funding, stigma. Yeah, I mean, in funding, and I don't want to pick on one treatment, but I will. And it's Vivitrol. And it was something that I struggled with from a budget standpoint when I was a treatment court administrator, even though we provided it to anybody we could who is medically appropriate and willing, and we would rob our piggy banks to pay for it, but it is cost prohibitive, right? There has got to be some middle ground for the big farm companies and our state legislative body or the big wigs to negotiate better rates. It's well above my pay grade. I just know this, that it is outside of the reach of almost all of us to pay for those once a month injectables if you get the injectable. And there is also the oral form naltrexone in the pill form. But again, it's not just naltrexone, right? Buprenorphine is expensive too. And methadone is expensive, especially if I'm homeless and I don't even have a job, right? So I think across the board, it's fair to pick on all three, knowing that this isn't cheap. We need more money, and we shouldn't have to just be so aggressive with going after dollars all the time. There has to be some give. Again, some middle ground where we can make it more palatable for us to go after these efficacious treatments and make it accessible to all of us, not just the few. We need it for everybody because it works and it saves lives. Stigma, I'll say this and I'll move on real quick. It still surprises me today when I hear people who they themselves are in recovery who do not acknowledge in an AA or an NA meeting, those people sitting beside them that are getting ready to stand up and acknowledge 12 months of recovery. But there's one catch. For those 12 months, I've been on methadone, or I was on Vivitrol or buprenorphine. There's some peers in my group that don't acknowledge that as me being in recovery. And no, Sean doesn't have that time of sobriety. That's unfortunate. And I would gently push back against that sentiment and say that we absolutely should. And we should really embrace that sobriety that they've claimed over 12 months, worked so hard to get. And we should shout that from the rooftops. I think this is about lifting people up and really acknowledging the success that's individualized for each of us and not tearing people down or diminishing the hard effort and work that we all put into this. Period. So I'm checking my watch. I've got 16 minutes and I do want to leave a little bit of time for Q&A, but as I mentioned to Johnny before you guys get in here, I'm notorious for going over it. So I'll try to get through this quickly. So let's talk about this EPICC program. And before I get into this slide, I just want to share, and I probably should have put this in there too. So EPICC was originally launched in 2016 in the Eastern region, specifically in December, right before 2017 kicked off. And we launched this model because we had community members in the Eastern region losing their lives way too much, way too often, every single day it seemed. And we wanted to leverage our hospitals where all these community members were showing up at. And we wanted to create a model where we wanted to meet them where they're at. That means at the ED at 2 a.m. in the morning on Christmas Eve, on New Year's Eve. So we launched back then. And since that time, as you can see down here, we have expanded to the central region in Columbia, Southwest, the Springfield, Branson region, as well as the Western region, Kansas City and your neck of the woods. So again, going back to 2016, realizing the importance that we have got to do this 24/7, 365. And I'll tell you, we didn't know how we were going to do it then because we only had 2 certified peer specialists right out of the gate. But I'll tell you what, we did it. They did it. And fortunately, I can tell you today, we have 30 certified peer specialists serving through the EPICC program statewide. And we still don't have enough. But again, we do provide a 24/7, 365 infrastructure where we link community members, patients from the hospital to community level care. And that could be a number of resources. Again, understanding that us getting Sean to a pharmacotherapy appointment, psychosocial education, just my therapy, that is really taking second seat to those underlying core issues that we quickly realize once we're sitting bedside with me. Maybe it's homelessness, transportation. Okay, so Sean, how are you going to get to the treatment, the ADA provider appointment that I'm going to set up for you tomorrow? Getting through all of those. Super important that we address that concurrent to the underlying issue of the use disorder. The EPICC program and this 10,000 figure is a little bit dated. Apologies there. We're closer to around 13,000 to date. So we've reached a lot of community members. And one thing that I will point out, just seeing the ripple effect of methamphetamine, seeing the increase of fentanyl on the street, knowing that it's being laced in pressed pills, cocaine, or methamphetamine, we really wanted to do more via our model to expand our eligibility criteria beyond opioids to include alcohol and stimulant use disorder. And again, this is based on data. This is based on what we're seeing at the community level via data and focusing limited resources. So I'm very excited to leverage our team statewide to do a small little dent and to just serve more thoughtfully in this space. So EPICC, if I likened EPICC to an automobile chassis, it would have 2 models. The first, which I don't have a slide for, which I believe Dr. Farr spoke to, was, and others, is a recovery-oriented system of care. And to me, that means, if I were to crystallize that, it's meeting folks where they're at. It's designing a program that really leverages and harnesses all of the community, understanding that we have got to provide a wraparound approach for Sean. So let me illustrate and give you a little example. In the Eastern region, we understood it was going to be hard to get some of our pregnant moms that we served, or mothers or fathers with children, to engage in treatment when they can't afford childcare. So it's making connections to whether it's a faith-based community, other childcare agencies that might want to do a little pro bono work, food pantries, housing authorities, to meet those needs. Why? Because if we didn't, Sean Billings would not show up to treatment. Not because I didn't want it. It's because I have to watch my kids. It's because I didn't have a car to get there. It's because I'm walking the streets and man, I'm just trying to find my next meal. I can't even think about what you're talking about with treatment. The second would be screening, brief intervention, and referral to treatment. Every opportunity that I've had throughout my professional career to be a part of the design, implementation, and execution of a program, it has followed suit with this. And this is endorsed by the Substance Abuse and Mental Health Services Administration, and it works. So within our small model, and this certainly isn't exhaustive, but just real succinctly, we're about screening, right? Standardizing, having a standardized screening and assessment tool to discern the need. And I would go so far that this needs to be a behavioral health screening, not just an SUD screening. Again, if we're not discerning these needs at the community level, excuse me, how in the world are we going to know that it's there? Oftentimes, behavioral health malady is hidden. And due to stigma, shame, we're not readily giving that information up, right? It's only if we get a positive tox screen or something along those lines that, creates those red flags where it's like, something's going on with Sean. I'm going to have to do some probing. So screening, so important. Overdose education and naloxone distribution. A core underpinning, not only within EPICC, certainly within SOR, nationally, globally, because it saves lives. Medication-assisted treatment, the referral to treatment is that warm handoff with that recovery support. They are the gateway. They're the taxi cab, the Uber, the Lyft, literally and metaphorically, right? Greeting me at bedside, sitting down with me, with their eyes, eye level, right? Using their motivational interviewing, being empathetic, being kind, thoughtful, being mindful of what's coming out of their mouths. All of that plays weight. All of it is so important. This right here is just, and I tried to quickly find a Kansas City magnet, but what you're looking at is a central region magnet that we have these for all of our regions, and we slap these over every mental service that they'll allow us to in their emergency departments, as well as other floors within the hospital. But it quickly just gives a highlight of the EPICC project, the referral eligibility, the eligibility criteria, and then most importantly, the phone number, right? Now, one thing that I'll share just real quick that we're in the process of making are these little badge buddies. And on these badge buddies, they will tether to your ID that the hospital staff have, and then it'll just connect to the back. So instead of having to scramble around and look for it, it's right there hanging around their necks. So we're going to print out a couple of thousand of those and hand those out statewide to hopefully increase referral volume. And just so folks don't forget about us. So the strength of a recovery coach model. I'm not going to read these ad nauseum, but I'll say that the peers that we hired through EPICC, they themselves have lived experience. They can connect with community members in a way that I can't, that I often hear from practitioners, whether it's a medical doctor, it's a nurse practitioner, a nurse, social worker. They connect in a much different way, much quicker. The community member, the patient, they're just more open, more receptive to what's coming out of that recovery coach's mouth. Again, using the recovery coach as a vehicle, as a catalyst to really drive change in me, knowing that me, the patient, me, the community member, is going to have to do 99.9% of the work. But boy, don't underestimate that 0.01% of me holding that hand of that community member, showing up at that ADM appointment, knowing that me, I'm totally scared. This is my first time going to treatment. So yeah, our coaches are going to be there waiting for them at that initial intake appointment, maybe not the whole time, but certainly when they're sitting in the lobby thinking about, well, I'm going to go out and smoke another cigarette. And you know what? After that, I might just catch the bus. I'm freaking out, super stressed. Having that coach sitting in the waiting room, just because the coaches have heard it from them so many times now, that, man, Sean, I really appreciate you showing up. You don't know what that meant to me. I was thinking about bailing, but then I saw you sitting in the lobby. I walked to the door, and, I kept my tush in the chair and I went through with it. So I can't speak enough about the power that they possess within this workforce itself to really pivot that ambivalence in the community members that just need them. They need more support. It's instant social capital is what these recovery coaches provide. I've kind of walked through this model. The patient overdoses in the ED, the induction occurs, the RC is contacted. They will be at that emergency department within 60 minutes of outreach, referral. The ED physician provides the bridge script as appropriate, and then the recovery coach works his magic or her magic, and they get me squared away. Again, it's more than just recovery and treatment. It is, thanks, Johnny, it is the social determinants of health, right? It's all those other things that are also so important to me as a human being that also need to be addressed. So real quick, there was a lot of talk, well, some talk, just about naloxone leave behind initiatives, the importance of really tapping our first responders on the shoulder and seeing how we can align some of the great work that each of us are doing, and then tether that specifically within the first responder workforce as appropriate, as their organizational readiness allows. And what the DOTS project is succinctly, is it's a curricula that we provide. They, being the Missouri Institute of Mental Health, they drive this program throughout the state to provide training on resilience, understanding that, boy, our first responders see all kinds of trauma. The burnout rate is huge. You know, they need some extra tools in their belt, right? So we're going to do everything in our power just to make them more resilient. Give them 2, 4, 6 ears, listen to them, right? Do a lot of listening. Community, give them key facts on systemic context and understanding people who use drugs. That's all that to say, humanize us with use disorder, right? Make them see us as human beings. And I'm not saying that they don't, but I think after the 25th call that Officer Billings, me, I come to, Johnny's house, not to pick on you, Johnny, but I will, that 25th time, right? Now I'm not seeing Johnny as Johnny anymore. I'm seeing Johnny as, why can't he get his stuff together? Because I don't understand that he's got a chronic brain disease as much as I should. So super important that we do that. And then outsourcing, that's where EPICC comes in. Providing EMS with a conduit for a Sean Billings when I tell them, thank you for bringing me back to life with the 2 things of Narcan that you just administered to me. But when you ask me, do I want to get transported to the hospital? It's an absolute no. For those instances, knowing that I still need that care coordination, and potentially EPICC, they can provide that EPICC hotline number to that community member so they themselves can refer themselves if interested. So important. Again, outsourcing, connecting, linking. So looking ahead to 2022, an increased focus on OE&D. We need more naloxone in the hands of everybody. My grandma, my grandpa, law enforcement, you name it. Schools, supporting statewide integration of Missouri's PDMP. It's so important. You know, the real work happens once we have it. Data in, data out. We can have a Ferrari of platforms, but if we don't have a good driver and good stewards of people putting in that data, we're not going to get good data out. So there has to be accountability once we get our system up and running. Strategic planning, this is on our hearts at the Missouri Hospital Association in 2022, is driving more work in equity-centered trauma-informed care, expanding MHA's bridge model, EPICC, beyond opioids to include alcohol and stimulants. We want to make sure that that workforce peers, as well as other clinical staff serving through that program, that we do our due diligence to make sure we can absorb that expansion, and we do it well, and we do it thoughtfully. Continued focus on establishing a more robust surveillance infrastructure. You know, this is something that I'll tell you in the last 21 plus months, once COVID hit us, it's been crippling. And that's where our Quality Value Initiative Consortium, we heard from Dr. Farr, Dr. Hagel, and others earlier, they are part of our solution to really do a better job of making informed decisions, both at a micro and a macro level, as far as what we're doing well. What aren't we doing well? We need them to help us make better decisions for our community members. We certainly don't want to operate within an anecdotal armchair. We want this to be informed. And then addressing Missouri's substance use disorder response through a multidisciplinary approach. Again, it takes a village. So I'm right at 2, and now I'm going to be quiet. I believe that is my slide deck, and I left 0 time for questions.
That is impeccable timing. I think we could reserve a few more minutes if we have to. If anybody has any questions, I may have to reclaim the host option from you, Sean.
Yeah, let me
to make
stop
that
sharing.
happen. So if anybody has any questions for Sean right now, go ahead and send me a chat, and I can open up your mic and let you ask him here. Otherwise, if you wanted to wait and have a chat later. There was some good information in there too, Sean, that I will copy and paste and put in the chat on the platform, and for everyone as well. Daniel,
Yeah, and one thing I'd meant to do, but I'm not a good multitasker, is I had all these links I was going to blast in there. One of which, there was a lot of talk about those fentanyl test strips, and 2 of our partners, the Missouri Institute of Mental Health and the Missouri Department of Mental Health, they came up with a great one-pager, right? And it's talking about, okay, so you're right, it is by statute right now considered a drug paraphernalia, but if used on label, in other words, those fentanyl test strips, if we communicate that, look, Sean, no, you don't just get a drug and use it that way, you use it on label. After you've used the drug, pee in a cup, and then you use the testing strip. I just wanted to share that one-pager. A lot of thought went into it, and as appropriate, if nothing else, it could be used as a guide as your state thinks through how or how not to communicate the utilization of FTS statewide, because I know it's a challenge that we've had.
Sean, we do have a late question here, if you don't mind.
Yeah.
It's from Kelly Nightingale, and Kelly, I will open up your. Yeah, I'm not sure I know how to open it up. So anyway, I'll just ask the question for her. She says, speaking of evaluation, what type of outcome measures are reasonable and effective for the recovery coach model?
Well, what a really good question. And I don't know that I'm entirely qualified to answer that. And I would probably pick on some of our researchers, but I will take a stab at it. And I'll say this, success is operationalized in many different ways. And within the EPICC model, I know one thing that is near and dear to my heart is back in 2016, the whole reason why we launched this model was to save lives and to decrease ED utilization, right? Understanding that Sean Billings landing up in the ED twice a week is no good for Sean Billings, and I'm going to end up passing away unless I connect me at the community level. So one of the outcome measures that I'm looking to, that I'm encouraging our evaluation efforts to focus on, is reduced ED utilization. Also, demonstrating that by leveraging not only pharmacotherapy, but leveraging these peers are really helping with treatment retention. Now, as far as like teasing out other external factors that would also play weight, I would leave that to the PhDs. That's well above my pay grade. But I think it's really looking at, and then also I would say, how many folks are these coaches able to connect to food pantries, to childcare services, to transportation, to houses? I think those are other markers of success that really speaks to their ability to link and connect and bring community members back into the fold of their communities.
Thank you. And she said she appreciated the answer. A lot of thank yous. Again, there's some good input from a couple of Daniel Warren has some really good stuff in here. Anthony Strickland, Amy Phillips. But as for right now, we will go ahead and adjourn this session. Feel free to reach out to Sean and please visit the platform for the chat and revisit some of this stuff. Good stuff. Thank you again, Sean.
Yeah, thank you so much. I just appreciate that people showed up, especially after lunch, right? I saw like 59 or so. That was pretty good.
I think you peaked at 61.
Hey, I'll take that.
Yeah,
I'll take
nice
that
job.
61. Yeah.
Good stuff. And I'm just gonna hang around and make sure everybody
Yeah.
gets in and
Favor
out
to
of
ask.
here as needed.
Johnny, so I want to do two things. I would love to get a copy of the transcript of the case, the chat, just so I don't miss anything. And then
Yep.
also I do have some resources that I'd like to blast out to this group. Can I just feed those to you? Do I give them to Krista?
I would probably give it to her.
Okay. Yep.
I know there's a way to upload it on the platform,
Oh yeah, that's right. That's right.
but I'm not 100% certain
Sure.
how that all works. But yeah, I mean, and the platform will be available for quite some time. So
Okay.
at any point in time, if we need to, we can upload whatever email addresses when people sign up. We can send it out in a mass way, one way or another.
Good deal.
I need to figure out how to attempt. I think I can just copy and paste the chat into the platform chat. I'll take my direct messages out. I was communicating with one of my colleagues. I'll take that out because it pertains to
Yeah. Yeah.
But otherwise, yeah, great job, man. Your timing was just perfect.
Well, that's the Lord. That's not me. I always say a little prayer before I go up. I tell you, I'm notorious for I'll be like on slide 15 and it's 155 and I've got 15 slides to go. It's like, oh boy.
Yep. Then you start abbreviating and clicking fast because you want to get all the information out there, obviously. And yeah, time constraints that's a bummer.
Yeah.
Well, otherwise, I think I'm going to go ahead and close this out.
Yep. Sounds good. You were a great moderator. Thanks for everything. And yeah, hopefully I see you next year.
Absolutely. Enjoy the rest of your day.
In person. Yep, you too. Take care,
Yes,
Johnny.
let's do in person.
Yeah, I'll grow my beard out too.
I'm going to keep you to that.
All right. All right. I'll see you, buddy. Take care. Yeah.
See ya.